right, thank you so much. So I guess we'll get started. Good morning, everyone. Today we'll be talking about tumors of the jugular foramen, a very fun topic in our subspecialty. Let's see if my slides work. There we go. All right, so we're gonna start with talking about the anatomy of the jugular foramen, and then we'll touch upon the different tumor types that can be found in this region, how they can present, and some of the common workups, and also the available treatment options. So lesions of the jugular foramen, as we know, are among the challenging tumors of the skull base, and this is mainly due to the unique anatomy of this region. These are less common than the lesions of the internal auditory canal and cerebellopontine angle, but they can also extend intracranially and also extracranially, and sometimes even into the neck. And because of their variable sizes, and also different involved organs, they often require a multidisciplinary approach. The jugular foramen is where essentially the sigmoid sinus exits the skull to become the internal jugular vein, and it is bound by the temporal bone anterolaterally and by the occipital bone posteromedially. And the superior extent of it can vary from patient to patient. It can even sometimes come in close proximity or contact with the middle ear structures or the capsules. The carotid artery is essentially just anterior to the foramen, and the facial nerve is lateral to it. The foramen is classically divided in two different compartments, pars vascularis and pars nervosa, and these are usually divided by a fibrous and a bony ridge. The vascular component is slightly larger, and actually each component does include both vascular and neural components. The pars nervosa is usually occupied by cranial nerve 9 and the inferior petrosal sinus, and the pars vascularis is occupied by the cranial nerves 10 and 11, as well as the jugular bulb. Intracranially, usually there are two dural openings into the foramen. The superior one is occupied by the cranial nerve 9, which passes into the pars nervosa, and the lower one that is occupied by cranial nerves 10 and 11, and these pass into the anteromedial portion of the pars vascularis. And the cranial nerves 10 and 11 may also may or may not pass through a small bony canal within the jugular foramen. So these nerves usually exit the skull base in close proximity to each other and the other structures. Cranial nerve 9 usually exits most anterior, and it then travels anterior to the carotid artery. Vagus nerve, it lies medial to cranial nerve 9 and 11, and it extends inferiorly in between the carotid and the jugular vein, and the accessory nerve exits most posterior, and it travels over the IJ posteriorly, and it is often encountered during neck dissections. The jugular venous system essentially is the main venous drainage pathway of the intracranial structures in the brain. And the main vessels that empty into the bulb are the sigmoid sinus and the inferior petrosal sinus. And the inferior petrosal sinus essentially drains the clavicle region, and usually is not encountered unless the tumor is pretty large and the dissection needs to be extended further anteriorly and medially. So tumors of this region can be challenging to treat due to their unique location and proximity to lower cranial nerves and major vessels of the brain. Injury to lower cranial nerves are common, and facial nerve, even though it is lateral to the foramen, and larger tumors can also be involved or even injured during the surgery, and extreme caution must be taken when resecting these tumors. Many of these patients can present with normal hearing, but some will have hearing loss, and usually this is a conductive hearing loss from the tumor growing into the middle ear and pressing on the ossicles. But if it does invade the otic capsule and affects the cochlea or vestibule, it can then result in sensorineural hearing loss. And usually there are three planes of extension and growth of the tumor. Medially would grow intradurally. If it grows anteriorly, it would be into the petrous bone, and if they grow inferiorly, they're going to go extracranial and follow the major vessels into the neck. The most common lesion of this region is the glomus jugulare by far, followed by schwannomas of the lower cranial nerves and meningiomas. We will focus mainly today on glomus jugularis, and we'll touch upon schwannomas and meningiomas as well. But you could also get metastasis from other parts of the body, and also you can have chondrosarcomas, chondromas. In this area, in the lymphatic sac, tumors can grow towards the jugular foramen, and sometimes you can have non-tumorous lesions such as aneurysms and vessel abnormalities. So the term glomus is actually considered to be a misnomer, and these are better called paragangliomas due to their nature, and they're also called non-chromaffin paragangliomas or chemodactomas. They have an incidence of about 1 to 1.3 per million of the population. This tumor was first described by Rosenwasser in 1941 as a carotid body-like tumor that occurs in the temporal bone. But 1 to 3% of these can be endocrinologically active, and they can secrete epinephrine, norepinephrine, or dopamine. And usually these are monitored by checking the patient's urine for VMA and metanephrine products. This is, again, by far the most common tumor of the jugular foramen. There's a female preponderance, and the ratio of it varies from study to study. In some studies have reported a 3-to-1 ratio, and others up to a 6-to-1 ratio of these being more common in females. And usually they peak around the 5th decade of life. 7 to 10% of the patients can present with multiple tumors, and they can have a 4% rate of malignant degeneration. From a histological perspective, malignancy may be difficult to diagnose. Essentially, they can look the same, but if there is presence of a distant metastasis, then that would establish a diagnosis of malignancy in these tumors. As mentioned, these essentially arise from the paraganglion cells, and therefore paraganglioma better describes these tumors. The paraganglia of the temporal bone are usually ovoid and lobulated bodies that measure about 0.1 to 1.5 millimeter. And on average, 3 paraganglia can be found in each ear, and they're typically along the course of the Jacobson's nerve or Arnold's nerve. And the primary blood supply to these paraganglia is provided by the ascending pharyngeal artery. Grossly during surgery or even on examination, if they can be visualized in microscopic ear exam, they present as deep red, purple, or brown-gray color tumors. They are usually encapsulated and have a firm rubbery consistency. They're highly vascular, and they can certainly infiltrate locally and be locally invasive and erode the structures around them. Microscopically, paragangliomas resemble adrenal pheochromocytomas. They contain all of the cellular elements normally present in paraganglion cells, including chief cells, sustentacular cells, and a rich supporting vascular network, which together they create the so-called Zell-Bottom pattern that has been described. These tumors can be sporadic and also can occur as a familial disorder. The familial head and neck paragangliomas are associated with germline mutations and genes encoding subunits of succinate dehydrogenase or SDH, which plays an important role in the Krebs cycle. There are genetic testings that have been developed, and this is an emerging field in evaluating these tumors, but the most cost-effective way of screening for these tumors and these genetic mutations are still not well established. The incidence of the familial paraganglioma is estimated to be up to 20%. They can present with bilateral tumors, and they can manifest at an earlier age. When they are inherited, there is usually an autosomal dominant pattern with incomplete penetration. And presenting symptoms can vary, depends on the size of the tumor and the location and the structures that it involves. The most common presenting symptoms are usually pulsatile tinnitus, hearing loss, ear fullness, Talgia, and also lower cranial nerve symptoms such as hoarseness and dysphagia. As mentioned, hearing loss is usually conductive, but if it erodes the structures, and if they involve the capsule structures, they can cause sensorineural hearing loss. And in case of a tumor that has secretory features, then patients can also suffer from palpitations, sweating, flushing, syncopes, and hypertension. So when evaluating these tumors, one must be paying attention to these systemic symptoms as well. If the cranial nerves are involved, usually it's at the jugular foramen level, and on examination, pretty much on a microscopic exam, if they extend into the middle ear, a red pulsating mass can be visualized behind the tympanic membrane. There have been some studies trying to kind of correlate clinical symptoms with the size or extent of the tumors, but usually these are not reliable, and imaging would be paramount. CT scan would be a good starting study. Usually on CT scan of temporal bones, we would see irregularly shaped homogeneous soft tissue mass that involves the jugular foramen, and it can extend to the surrounding structures. It can enlarge the foramen, and unlike schwannomas that we will touch upon later, there can be a moth-eaten appearance of the bone around the tumor that reveals the primitive nature of the paragangliomas. MRI would be a great next study, and often is ordered together with CT scan. It's great to delineate the intracranial or neck extension of the paragangliomas. On pre-contrast images, these tumors have a T1 iso-intense appearance and a T2 hyper-intense appearance, and they obviously can enhance with contrast. On post-contrast images, you can have the classic salt and pepper appearance, which is due to the flow voids that can be seen in these tumors, and middle ear will often be involved. Some surgeons may consider angiography for diagnostic purposes, but is often considered for pre-op embolization. And if four-vessel angiography is performed, it helps with evaluating the major feeding vessels and also involvement of the carotid artery and essentially, the vascularity of the tumor. There have been different classification systems to describe glomus jugularis. The classification proposed by De La Cruz is particularly useful in planning the clinical management of the patients with glomus tumors. And the reason is that essentially the classification describes the extent of the tumor by the involved structures, and it can certainly help in directing management options for these patients. The classical approach are for simple glomus tympanicums, which would be not of the jugular foramen, but of the same nature of tumor, but only limited to the middle ear. Then a transcanal approach would be considered if it involves the middle ear and mastoid. A mastoidectomy with extended facial recess can be all that is needed to resect these tumors. For more extensive tumors, mastoidectomy with neck dissection and possible rerouting of the facial nerve may be necessary. And for more advanced involvements, such as carotid artery or intracranial growth of the tumor, then infratemporal fossa or transcondylar approaches could be appropriate. The most commonly used classification is the Fish classification. Class A describes a glomus tympanicum. Class B describes a tumor that is involving both middle ear and the mastoid. Class C is what we would consider a true glomus jugulare. And then it can involve the carotid foramen, which would be a C1. And then depending on how far up the carotid artery grows, it can have other classifications from C2 through C4. And the type D tumors have intracranial extensions. The type DE tumors have extracranial extension, but they remain extradural. Type DI tumors have intracranial and intradural extension. And depending on the size of them, they are further classified into subtypes 1 and 2. Another proposed classification system is the Glasscock-Jackson one. And this is simpler. And again, for the most part, these classification systems rely upon describing the extent of the tumor and the involvement of the surrounding structures to help the surgeons communicate with each other and also to plan for treatment such as surgery. So in terms of the treatment options, generally one can consider simple observation because these are, for the most part, benign tumors. Surgery has been the gold standard and historical standard in removing the tumors, and it can further be divided into gross total resection and subtotal resection. Radiation has also been used and described for these tumors. It can be as a primary treatment or as adjuvant or salvage treatment after a subtotal resection. And a lot of factors will play into the decision-making process, having a discussion with the patient about their expectations and about the natural history of these tumors is essential. And the surgeon must pay attention to the patient's age and health, consider the size and extent of the tumor, and a decision can be made in terms of which route to take for each particular patient. Preoperative embolization can certainly help with minimizing intraoperative bleeding. It is usually done about 24 to 72 hours prior to the surgery. It can be done earlier than that, but classically the concern has been risk of recanalization if it is done much earlier than that. There are limited but possible risks of transient or even permanent cranial nerve damage as a result of embolization or even stroke, and the patient must certainly be counseled about these risks. We kind of talked about the surgical option, which has been the historical standard. There are different approaches that we will touch upon, and the main determining factor would be the extent of the disease and also the goal of the surgery, whether gross total resection is being considered or is planned for a subtotal resection with wait and scan approach or adjuvant radiation therapy. The degree of carotid involvement, again, varies, but it is determined with preoperative imaging. One key factor in managing glomus jugularis would be achieving proximal and distal control of the major vessels of the foramen, including carotid artery and the jugular foramen. And larger tumors, opening the neck and achieving this early access can certainly be helpful and even crucial in controlling any potential intraoperative bleeding. And identification of the lower cranial nerves early on can also help with minimizing risk of injury to these nerves during the surgical approach, regardless of the goal, whether it be gross total or subtotal resection. Smaller tumors that are limited to middle ear and mastoid, such as glomus tympanicums, are addressed through a transcanal or mastoidectomy with facial recess approach. For more larger tumors, including essentially standard glomus jugulari tumor, a neck approach can be added and should be considered. For small ones that are limited to the bulb, usually mastoidectomy with facial recess would be done, and then the mastoid tip can be amputated, and the facial nerve can also be identified along with the digastric muscle and retracted and freed to provide access to the jugular foramen for the surgeon. And facial nerve rerouting can be, again, considered depending on the anatomy of the patient and the degree of involvement and the size of the tumor. This can be total decompression of the facial nerve from second genu throughout the entire vertical segment. And also fallopian canal bridge technique can also be done where just the facial nerve is preserved, but a very thin bony canal is left around it, and then the surgery is performed around this canal bridge. Infratemporal fossa approach is reserved for more advanced tumors. This was developed by Fish and is for larger tumors. Essentially, the key steps are managing the external auditory canal and the tympanic ring, and this may even include or can include, or in certain cases should include, closure of the external auditory canal. A mastoidectomy with neck exposure is done. Facial nerve must be identified early on and transposed or rerouted. And this is followed by identifying the lower cranial nerves, the carotid artery, and finally with tumor removal and vessel ligation. And if there's intracranial extension of the tumor, it can also be resected. The classic teaching has been that if the blood loss has been manageable, it is attempted at the same time. But in certain cases where there are risk factors or the bleeding has been excessive, it can be planned as a stage 2 surgery or even partial resection. These situations can be considered. And if intradural resection is performed, often lumbar drain placement would be necessary to prevent complications. If tumors extend towards the foramen magnum, then a transcondylar approach would be appropriate, which would essentially be similar to and also called as a far lateral approach. A lazy S incision is usually performed. The initial dissection started as like an extended retrosigmoid essentially, and then it is extended inferiorly towards the foramen magnum. The cranial cervical junction and also the vertebral artery need to be identified and addressed, and usually neurosurgeon would also be involved in these joint surgeries. Now, subtotal resection has gained popularity over time, and the goals behind it would be to minimize patient morbidity, and it can also be considered in patients who are older or are unhealthy with multiple comorbid conditions. It can also be considered in younger patients with really large tumors and intact lower cranial nerves and very minimal symptoms, including mainly just oral symptoms. Published data on these reports have been coming out, but overall, the majority of the studies published have a short follow-up. One of the first ones that described this approach was published in 2005, describing 5 patients with subtotal resection that underwent adjuvant gamma knife surgery. They reported that all patients were treated on an outpatient basis without any need for blood transfusion, which would be, I would say, very significant. There were no incidents of change in cranial nerve function, meaning if they had a normal function, they were able to preserve it, which again sounds, I guess, very good. But also the sample size was pretty small, only 5 patients. And all of these patients had improvement or resolution of their pulsatil tinnitus, and also their preoperative hearing levels were preserved. The tumor volume was reported as stable or reduced in all of the patients at a mean follow-up of 19 months, which again, as mentioned, is relatively speaking a short follow-up. And overall, based on this report, gamma knife with a mean peripheral dose of 15 gray was administered, and it was not associated with any significant immediate or delayed complications. One of the early larger studies that was published was by Dr. Fayad and Dr. Brackman, which reported the house clinic experience. 83 tumors of the jugular foramen were reviewed, and the outcomes were reported. These patients were seen and operated on between 1997 and 2008. About 67 glomus jugulari tumors, all fish C or D grades, 9 schwannomas and 7 meningiomas. About 74% underwent surgical excision, 18% had radiotherapy, which included gamma knife or proton beam radiation, and 8% were just observed with wait and scan approach. Overall, 81% gross total removal was achieved, and the lower cranial nerve deficit rate was up to 13% in patients with a less than C4 tumor size and up to 81% in larger tumors. And the recurrence rate at an average of 26 months was reported as 24%. Another study that was published in 2013 from Italy, and this was Dr. Sana's group. They reported 122 tumors between 1988 and 2012. Again, all fish C and D tumors. The gross total resection rate was 86%. 54% of the patients had some degree of lower cranial nerve deficit post-op that was new, and their recurrence rate was reported as 3.8%. And this table summarizes some of the other studies that, again, have been published about outcomes of surgery for jugular foramen tumors, mainly glomus jugularis. As kind of seen towards the second column from the right side, the gross total resection rate varied from approximately 80 to 96%. Recurrence rate, for the most part, was under 16%, and the rate of lower cranial nerve deficits, varied from study to study, but again, along the lines of the previously reported rates. So radiation is another option, as we just touched upon on it. It was initially attempted given the complexity of surgery for these tumors, and different modalities of radiation therapy have been tried in the past. Fractionated external beam radiation was used in early studies as primary or salvage therapy, and they reported 86 to almost 100% control rate. And in these studies, control rate is usually defined as either a stable size of the tumor or regression. And then the main factor obviously would be the length of follow-up for these studies that would be essential. And radiosurgery has also gained more popularity in recent decades, including gamma knife and cyberknife. One study in 2012, that was a multi-center study, they reported 132 patients that they underwent gamma knife surgery. 116 of these patients had fish C or D grade tumors, and they reported a 93% tumor control rate with a median follow-up of 50 months. And progression-free survival was about 85% in primary radiosurgery and 90% in salvage radiosurgery. During their reported follow-up, they did not encounter any malignant transformation, and about 11% of these patients, however, did have worsening cranial nerve function after having received the radiation. The second, kind of a large study that was published in 2011, it helped with kind of, again, further establishing radiosurgery as an option. This was a meta-analysis of 869 glomus jugulari patients, and they divided the patients into 4 different subgroups: gross total resection, subtotal resection, subtotal with adjuvant radiosurgery, and also primary radiosurgery. And they reported for control rate and rate of cranial nerve dysfunction. However, because this was a meta-analysis, they could not control for tumor size because some studies did not have a huge patient population. Looking at this table again, which is from this same study, majority of patients had a class C or D tumor size, and this was even more prominent in the group that underwent radiation. And they reported a full estimate control rate of 69% for patients that just underwent subtotal resection, which kind of makes sense because part of the tumor was left behind. With gross total resection, 86% control rate was achieved. And the group that had subtotal resection with adjuvant radiation, the rate was 71%. And the primary group that underwent radiosurgery was 95% of control during their follow-up. And again, for the most part, these studies, the group that undergoes radiation control is considered lack of documented growth or even regression in the size. And for the gross total resections, lack of recurrence would be and is considered a success and control of these tumors. And looking at the cranial nerve deficit, they were only able to report it for gross total resection and radiation groups because the other studies had a much lower sample size. But again, this would be along the reported numbers in the literature and kind of varied, and was as high as 38% in cranial nerve 9 and 40% cranial nerve 11. with gross solar resection, and as high as 12% again for cranial nerve 11 in the primary radiosurgery group. We did a meta-analysis when I was in residency on studies that were published between 2011 and 2016. This was published in 2017. We looked at 15 studies, including 511 patients. Eight of these studies used gamma knife radiosurgery, and the rest were equally divided between CyberKnife, LINAC, and external beam therapy. The mean marginal dose was 13.2 to 20 grays. The median follow-up varied from 27 to 148 months, and the pooled tumor control rate was 95%, and a new cranial nerve deficit was noted in 7 to 33% of these patients, which again was along the lines of the previously reported numbers. Observation or wait and scan approach is also another option that can be considered for the patient, especially in older patients. The natural history of these tumors is not well established because historically these tumors were considered locally invasive, and surgery was performed to remove them, or they were treated. However, there have been more studies published that kind of report on outcomes of just observing some of these patients. And the main consideration would be that even these tumors grow, usually they have a slow rate. And in the case of intervention, there is chance of potential complications, which can also happen with just watching the tumor as they grow. And obviously that would be the dilemma in this the decision-making, and a factor to discuss with the patients and take into consideration when making the decision for each individual patient. One of the larger studies that reported on Vaden scan approach was again by the Dr. Sana group in Italy. They in their study that they looked at 382 tumors between 1988 and 2012. All of the fish A or B tumors underwent surgery, but 47 of fish C and D tumors were observed. And then 23 of these patients actually had a minimum observation of 3 years with a median follow-up of 61 months. As we can see here in this table, which is from the same study, about 13% of the observed patients, the tumor actually regressed over the follow-up. 52% were stable, and some grew. Of those that grew, 31% only revealed a slow growth, and 4% revealed a fast growth. In the patients that were observed, the lower cranial nerve function remained stable in 65%, and this is kind of in the second picture down below. 5% the function got worse, and 30% actually did develop new deficit, which could arguably be said to be along the lines of the results with surgery or even with radiation. And the facial nerve function was also looked at, and 9% had deficits to begin with. And of those that did not have any facial nerve deficits, they reported 100% stability rate during their follow-up. And this is kind of what they came up in terms of recommendation for observational weight and scan approach. And the conclusion was that in patients older than 65 years of age, and those who have like a type C or D glomus jugularis, Vaden scan can be considered, and we would look at the growth rate, and if it's a slow-growing tumor, again, it would be appropriate to continue to observe, but if it's a fast-growing tumor, then treatment will need to be initiated. So now we're going to shift gears and look at some of non-paraganglioma tumors of the jugular foramen. Schwannomas are also very common. These are the second most common tumors of the jugular foramen. They're thought to be about 3 to 4% of all intracranial schwannomas and 1% of temporal bone lesions. These mainly arise from Schwann cells of the lower cranial nerves, but the vast majority are actually from cranial nerve 9 or 10. Just like glomus jugularis, there's a female preponderance, and the average age is about 37 years. at presentation. If they are seen sooner, such as in the first or second decade of life, one must suspect presence of neurofibromatosis and evaluate for it. These can also have a variable growth pattern. They can grow intracranially or extracranially. Unlike glomus jugularis, they tend to respect the bone around the jugular foramen. However, they can have scalloping effects. And the classic appearance is the dumbbell-shaped tumor that has been described in the literature. Presenting symptoms are, again, pretty much similar to glomus jugularis. They can present with hearing loss, lower cranial nerve deficits, vertigo. If they grow intracranially, they can cause ataxia, papilledema, and some of these may even be asymptomatic. Now, pulsatile tinnitus wouldn't be as common in these tumors, essentially because these are not as vascular as glomus jugularis, and they don't present with like middle ear mass as commonly as glomus jugularis do. Meningiomas are the third most common tumor of the jugular foramen. These are this region is thought to include up to 4% of all posterior fossa tumors, and again has a female preponderance. And just like the other tumors, the peak occurrence is in the fourth or fifth decade of life. And these, again, can be primary tumors of the jugular foramen, or it can be a secondary tumor from extension of a larger tumor, such as a petroclival meningioma. Meningiomas, they actually originate from arachnoidal cap cells, and these cells are very concentrated around the foramen and venous sinuses, and therefore this would be a common location to develop a meningioma. Similar to schwannomas, again, they can have various presentations and symptoms, and the growth patterns can be similar, and treatment approaches are, again, for the most part, the same as other tumors of this region. In terms of classification and grading, the WHO classification has classically been the most commonly used one, with grade 1 that includes the majority of meningiomas. About 90% is considered a typical tumor. Grade 2, which is about 7% of all tumors, considered atypical tumor, and a grade 3, which is considered anaplastic tumor and comprises up to 3% of all meningiomas. This is a nice kind of a side-by-side picture that compares CT findings of these three common tumors of the jugular foramen. On the left side, the panel, we see a glomus jugulare, and there is that classic moth-eaten appearance, which is due to permeative changes characteristic of paragangliomas. The middle pictures represent the meningioma and the sclerotic osseous changes that can be seen in the bone around the jugular foramen. And then the picture on the right is from schwannoma of the jugular foramen, and that kind of a classic scalloping of the foramen, and once an MRI is taken, the classic dumbbell-shaped tumor that can be seen. Glomus jugularis, again, would be detected on MRI based on their appearance, location, and also the so-called salt and pepper appearance. Meningiomas can, on the other hand, have a dural tail, as we see in this picture, and the classic finding of the schwannomas would be the classic dumbbell-shaped tumor around the jugular, or in the vicinity of the jugular foramen. Management options of these tumors are similar to glomus jugularis, and decision is based on the size, the growth pattern, the patient's age and comorbidity, and their preferences. If there is intracranial tumor that has only a little extension into the jugular foramen, such as a meningioma, then a retrosigmoid or transsigmoid or even a retrolabyrinthine approach can be considered. In the same study of Dr. Fayyad and Dr. Brackman that was published in 2010 with the house clinic experience, 9 schwannomas and 7 meningiomas were also included. And the recurrence occurred in 16 glomus jugularis and 2 of the schwannomas at an average follow-up of 26 months. And the treatment modality was 100% for schwannomas and 57% meningiomas, again, with surgery and radiation in only 14% of the meningiomas, and some of them were, again, observed, and this, again, would be due to the benign nature of these tumors. And in terms of new lower cranial nerve deficit after surgery, the rate was 18.9% in glomus jugularis, 22.2% of schwannomas, and also 50% of the meningiomas. Another study from University of Pittsburgh was published in 2007, and they kind of looked at the outcomes of schwannomas of the jugular foramen. This study was mainly looking at results of radiosurgery with gamma knife. They had 35 tumors, and these received a median marginal dose of 14 to 28 grays, and mean follow-up was 83 months. 17 of these tumors regressed, 16 were stable, and 2 progressed, and they reported a 5 and 10-year control rates of 97% and 94%. With no new cranial nerve deficits. 7 of them actually did improve according to what they reported, and 1 got slightly worse, and 27 were stable. This study out of University of Virginia, they looked at gamma knife surgery for meningiomas of skull base, and 255 patients underwent gamma knife surgery. And these did include jugular foramen meningiomas as well. And they kind of pulled the results and reported a progression-free survival of 96% and 78% at 5 and 10 years, and an 8.6% rate of developing new onset cranial nerve deficits. So I guess we'll kind of wrap it up here. Jugular foramen tumors continue to present a management challenge to neurologists, and this is mainly due to their unique location, vicinity to the major vessels of the brain, and the structures of the temporal bone, the lower cranial nerves, and as we kind of reviewed and touched upon these, they can have variable presenting symptoms. For the most part, these are benign, and the decision-making for the treatment options would be taking into consideration many factors, including patient's age, comorbidities, size of the tumor, their preferences, and available treatment options at the treatment center. Radiation has gained momentum as a viable strategy for these tumors, and radiosurgery has also presented itself as a new alternative to surgical excision that has been the historical gold standard. And obviously, more studies with longer follow-ups would be needed to look at the outcomes and to better counsel the patients. And when doing the surgery, the main factor would be to consider would be to see if gross total resection can be achieved, and also cranial nerves, including facial nerve and the lower ones, can be preserved, because their dysfunction and weakness can be detrimental to the health of the patient. All right, well, that's all I had for today. Thank you so much for having me, and it's been an honor and pleasure to present today.